So I am delighted to introduce our next session to you all this afternoon. This session will provide information around behavioral medicine interventions for pain management, as well as the use of behavioral pain medicine to teach patients coping strategies for dealing with pain intensity and improving their quality of life. We will also take a deeper look at the use of acupuncture in a clinical setting to treat pain. Our speakers for the session are Dr. Laura Gray and Dr. Sarah Rees-Strimson from Children's National Hospital. Dr. Laura Gray is a pediatric psychologist who completed her graduate training in clinical psychology at George Washington University, her internship at Boston Children's Hospital, and her pediatric pain fellowship at the Pain Treatment Service at Boston Children's Hospital. She provides behavioral treatments to patients with chronic pain conditions, acute and chronic headaches, concussions, and other nervous system disorders. Her clinical and research interests include the impact of pain on social, emotional, and academic functioning, the associations of perfectionism and pain, and interventions that help improve patients' quality of life. Dr. Sarah Rees-Strimson is an associate professor of pediatrics and anesthesiology at George Washington University. Her clinical practice at Children's National Hospital includes work as a pediatric anesthesiologist, acute pain medicine physician, and acupuncturist. Her research interests include investigating the resumption of infant feeding reflexes following propofol anesthesia for MRIs and the effects of acupuncture in pain relief and reduction of opioid usage in patients hospitalized with sickle cell disease and vaso-occlusive crisis. Thank you to our speakers for joining us this afternoon, and we will begin with Dr. Gray.
Hello, I am Dr. Gray, and as you just heard, I am one of the pain psychologists at Children's National Hospital, and I'm going to talk to you some about behavioral pain medicine today. So first, neither myself or Dr. Rees have any disclosures. So what is behavioral pain medicine? This may be something you've heard of, it may be something that you haven't. Behavioral pain medicine is teaching patients behavioral strategies to help them to be able to alter their pain experience. Generally, our goal is to reduce their pain. So it's teaching things such as relaxation, distraction, cognitive restructuring, helping them to identify and to apply lifestyle changes that can help to be able to increase their functioning and ultimately to reduce their pain. So the benefits of behavioral medicine is it increases patients' self-efficacy. This is the empowering piece, that they learn how they can do things that can help to control their pain experience and that they can get back in control of their life. Can decrease patients' reliance on medications, increasing their functioning, and often it decreases pain, although our goal is always to be increasing their functioning, and typically it also happens that pain is decreased. So why is there a picture of a bus? This is one of the examples that I am often talking about with patients. They say that what happens over time is chronic pain starts to take over patients' lives, and that it gets to the point that pain is often what's driving the bus. It's what is dictating and determining what's happening in their life and what comes next. And what we want is to get the patients back into the driver's seat so that the patient is the one who's driving the bus in their life, and that pain is taking a back seat. It might be that pain causes some detours, but it's not dictating the direction or where they're going. So when should you refer to behavioral medicine? These are some examples of the types of patients that might benefit. So patients who are presenting with significant anxiety and or depression related to the pain, significant distress related to the pain. These are patients who are really having difficulty tolerating the pain and its impact on their life. Functional disability, that they're not doing the things that they were able to do before. If you believe that the patient's physical symptoms are disproportionate from what you would expect based on medical or objective data, that would be an indicator that there would be some behavioral strategies could help to be able to improve the pain experience. Also behavioral or emotional responses to pain. So this can include things like dysregulated or aggressive behavior, significant mood changes, sleep disruption, which is a very common one. And then any suggestion of additional psychosocial stressors. So we know that stress impacts pain, and so patients who are experiencing new or persisting psychosocial stressors will likely have more difficulty with managing pain. So this is an example treatment protocol, so you can see the types of things that we do. So when patients will start with us, we will have an initial evaluation where we are collecting information about their pain experience, but also the ways that pain impacts their life, the things that pain gets in the way of. There, we are providing a lot of validation that their pain is real, that their experience of pain is real. It's not something that's made up. But that there's a lot of things that are going to impact that pain experience for them. So then we provide education. We talk about the gate control theory, which I will talk about later. Then we have patients return for follow-up sessions. So our follow-up sessions start with skill building. So this is helping patients to be able to build awareness of their physiological awareness, understanding how their body feels when it's under stress, how their body feels differently when they're in pain, when they're not in pain. Teaching patients skills like relaxation skills and distraction strategies, cognitive behavioral therapy strategies, and also teaching them how to implement lifestyle changes that we know can be very beneficial in reducing the pain experience. Then talking about activity pacing and behavioral activation. That's the skill building piece. Once patients have built this toolkit, then we move into creating their plans. So this is helping to problem solve barriers to making or maintaining these changes, talking about their pain and stress coping strategies they can use to increase comfort, and how they can plan ahead for managing setbacks. Then we'll talk about maintenance of how do they use all of these skills moving forward so that they can maintain their increased functioning, and how they can continue living life the way they want to with whatever pain that is that they're experiencing at that point. So why does it work? So the first piece is that all pain is processed in your brain, right? So although patients, we are emphasizing to them that they're not making it up, we know they're not making it up, but pain is experienced in your brain, that your brain is what's controlling. It's the control center that controls the experience of pain. So we talk about what I mentioned of the gate control theory of pain. And this is the idea that there is a gate at the base of your brain that when this gate is open, any pain signals that are being sent through your body are traveling up your spinal cord, they're processed in your brain, and then your brain's sending those signals back down. If that gate's open, all those pain messages can get back through quickly, and the pain experience or the pain volume is going to be louder, more intense. But when the gates are closed, at least partially closed, then the pain signals may be getting sent up to the brain. The brain's processing those pain signals, they're sending them back down, but some of those signals are getting blocked. They're not able to get through. So those descending pain signals that are going from your brain back to the body to tell the body where to experience pain are getting disrupted. And that's really the goal that we have with patients. So we talk about this gate control theory. We talk about things that open the gates or are going to turn up the volume on pain, and the things that close the gates that help to turn down the volume on pain and decrease the pain experience. So these things that I've mentioned, we'll talk some about relaxation, active distraction, activity and exercise, not overdoing it, not underdoing it, managing their cognitions, their thoughts, their emotions. These are all things that help to be able to close the pain gates, and we want patients to understand which things can work, and especially which things are going to work best for them. So often, sleep has been disrupted for patients with chronic pain. So pain impacts sleep, and sleep is one of the things that we know with poor sleep is going to further increase pain. So we're often starting with talking about sleep hygiene and sleep interventions. So sleep hygiene are any behaviors that help to be able to improve sleep quality. So we're identifying what are the barriers that are getting in the way of changing their sleep or improving their sleep, what is their typical sleep pattern, and then making recommendations for patients to be able to modify their sleep. So sleep hygiene strategies includes things like reserving your bed just for sleep, so you're not doing awake activities in bed, keeping a consistent sleep-wake schedule, limiting the time that you're in bed awake for patients with prolonged sleep onset, avoiding screens an hour before bed, having a really consistent and relaxing bedtime routine, avoiding excessive caffeine, and for patients whose sleep schedules are very off, helping them to gradually shift their sleep or return their sleep to a typical sleep schedule. We'll also do what's called behavioral therapy for insomnia. And it's similar, it's helping patients to be able to learn, identify which sleep changes they need to make, and then helping problem solve and helping them to make those changes over time. It includes things like restricting their sleep so that they're feeling more tired, that they're having a more sleepiness to be able to help with the sleep onset, and really controlling their sleep schedule. So we know that poor sleep leads to more pain, to worsen pain, and then that tends to lead to lower mood, depressed mood, which leads to worse coping strategies, less motivation to be applying the coping strategies that may be helpful, and that further worsens sleep. So this can become a very vicious cycle for patients experiencing chronic pain, and something that we're trying to help work with them to unwind. So treatment also includes relaxation training. So typically this is starting with diaphragmatic breathing, or what we refer to sometimes as belly breathing. This is a controlled style of breathing where you're taking slow, even, deep breaths. The goal of this is to be reducing muscle tension and ultimately helping to calm the body's stress response, which helps to reduce pain. For many of our patients, this is the most effective strategy. It's typically the one that we start with, and then we build from there to keep adding on. So other relaxation strategies include guided imagery. This is helping patients to be able to learn how to redirect their attention, their focus, essentially using your imagination to picture a calm, relaxing place vividly, picturing all of the different senses, what you hear, what you smell, what you taste, what you touch, what you're doing, activating more and more parts of their brain. This provides a sense of relaxation as the body responds similarly to being in that location, and it also helps to provide distraction and a sense of calm and safety. So then we'll teach progressive muscle relaxation, and this is really, it's a strategy helping to reduce overall muscle tension, where you start with one isolated muscle group, and you start by tensing those muscles and holding those muscles for about 30 seconds until the muscles start to get fatigued, and then you're slowly relaxing and releasing. And we're directing patients to be paying attention to the difference that it feels between whenever their muscles are tense and whenever they're relaxed. Then we progress through different parts of the body, tensing and relaxing muscles as they go. And again, the end result is reduced muscle tension and feeling more relaxed. Treatment also includes education and cognitive behavioral therapy. So we talk about the relationship among thoughts, feelings, and behaviors, and how this can impact patients' emotions and certainly can also impact their pain. We help patients understand their physiological responses, so identifying their emotions and that individual stress response for them, and talking about the way that stress impacts pain and that pain further impacts stress, identifying which are ways that they can start to make changes. We also work with patients to identify their thoughts, their behaviors, and any somatic precursors of pain exacerbation. So for some patients, one physical experience or a small pain here leads to a bigger pain response or a cascading response. So helping them to identify what might be some of the negative or unhelpful thought patterns they've developed over time, and helping them learn how to be able to change those thoughts, alter those thoughts, challenging the thoughts, or thought stopping. Treatment also includes what's called behavioral activation. So for many patients with pain, they have reduced their activities due to pain, and we want them to be gradually increasing their activities. So we start with identifying which are the most valued activities for them, the things that they enjoy the most, that they would be most excited about getting back to. Those activities will improve their quality of life, be most distracting, and be most effective for reducing pain. Then we talk about activity pacing, where moderation is key. So overdoing it or underdoing it is going to lead to exacerbated pain. So we help patients think about how to return to exercise, work, school, whichever things they're getting back to. Then we spend a lot of time talking about managing stress. So developing plans to manage the stressors for the activities that they have going on, managing their workload while they are working on increasing their functioning and while pain is still a big part of the picture. We also talk about distraction strategies. So active strategies are stronger than passive distraction strategies. They engage more parts of the brain, keep the brain more engaged and active. And we talk about how focusing on pain, thinking about pain, talking about pain, asking about pain increases the pain perception and can consolidate pain memories. And so helping patients to learn how they can control what they're focusing their attention on, and they can choose which activities to do that help to change that pain experience. We'll also talk about fear of pain. So for many patients over time, they've developed specific fear of pain or types of pain or certain situations. And those specific pain-related anxieties will lead to avoidance of activities due to fear of pain. And it further gets them stuck with low functioning. And so it's a gradual exposure of helping them to return and to face those fears and those feared activities and situations. We also incorporate what's called acceptance-based therapy, acceptance and commitment therapy. It's a third wave of the cognitive behavioral therapies, and it's really focused on helping patients to identify what are the areas in their life they can control, the things they can control, the things that are out of their control, thinking about what are their values that's most important to them, and how can they make values consistent decisions. So moving toward my values, was this action something that moved me toward my values or away from my values? Which things are in my control, what's out of my control, accepting what's out of my control, and working on finding ways that I can be moving towards my values. This really further increases this sense of empowerment and self-efficacy for patients. We incorporate mindfulness as well. This is helping patients learn strategies to focus on the present moment. It's non-judgmental, redirecting your focus and attention to a chosen activity or something that you're doing. So things like mindful eating, mindful walks, mindful movement, and incorporating these into their day as stress reduction and pain reduction strategies. Biofeedback, I'll just touch briefly on this. So biofeedback is something we will incorporate with some patients, and it's anything that is using physiological data as an indicator of the stress response. So typically there's a monitor similar to this picture that you see where we're connecting things to the patients, and it's things like their heart rate, their muscle tension, their body temperature, their heart rate variability, and they can track these on a screen. We can talk about how does their body respond when they're talking about or in a stressful response. They can see the change on the screen. Then they can apply their relaxation strategies and see the way that those indicators of that stress response can change, that they can control it. It increases their awareness of these subtle changes that they experience under stress, but also the things they can do to change that, to reverse that stress response, increasing a sense of calm and control. It also gets great buy-in for patients who maybe aren't sold on the mind-body connection. And this helps them really see that, oh, when I change my breathing, I can see the way that all of these other stress responses change as well. So you might be thinking, I have some patients that would be really good for this, but I have no idea how to sell this to them, right? So how do you have this discussion to refer them to behavioral medicine? Presentation is key. Often patients will hear a referral to any sort of psychotherapist as being, the doctor thinks I'm making this up and it's all in my head. And that is not what this is about, and it's not what you're saying, it's not what we're saying. So helping them to understand that pain is really complicated and that pain is all processed in their brain, and that pain psychologists or behavioral pain medicine is part of a multi or interdisciplinary treatment team, helping to be able to provide the most holistic and best approach for them. It's focused on teaching skills and strategies that will help the patient learn how they can reduce their intensity and frequency of pain experiences. Patients often find it helpful to know that these skills are relevant to help everyone deal with stress and anxieties that are just inevitable in life. So it's not going to be a waste of time. It's helpful to learn these strategies. It is often also important for you to emphasize that it takes time of setting those expectations for patients. So I often say, there is no easy button when it comes to fixing and correcting chronic pain. It's going to take time, so having that expectation that learning new skills, applying them, figuring out how to make changes will take some time, but ultimately it gives you the most control so that you have these skills in this toolbox that you can then use forever. So I appreciate your attention today. We'll hold the questions until after Dr. Reese's presentation. So I'll hand it over to Dr. Reese to talk about acupuncture.
Dr. Reese, we can share your presentation if you prefer.
Okay, let me see here. If I do share screen, we are going to do, I think, there, and I'm going to get started. Oops. Oh, hang on one second. Oh, I am not sure what's going on. Hold up.
No worries.
I am not sure what is being shared right now. Anything?
It's an orange PowerPoint.
Is it like looking with the cursor being funny?
No.
Okay, because what I'm doing, oh my goodness. Hold up. Are you seeing right now just my title, Acupuncture for Pain Control?
Yes.
Perfect. So that's not what I'm seeing. Let me change it a little bit. So, and then if I go to the next slide, do we see disclosures?
Yes.
Okay, perfect. I'm going to do that and ignore what's happening because I don't know what's going on. So I won't be looking at the camera because I'm doing a different screen, but we'll do it. All right. So I guess, am I good to get started at this point?
All set.
All right, cool. So I'm here to just talk about acupuncture as a sort of another non-opioid tool that people can start considering for patients who are having pain. I, like Dr. Gray, have nothing to disclose. I wish I made money from acupuncture, but I don't. I am, as previously mentioned at the top of the hour, I'm a pediatric anesthesiologist at Children's, and my new patients are always curious how I got into acupuncture, since the bulk of what I do day to day at Children's is actually doing anesthesia or acute pain management. But our group was approached back in 2014 about training some additional people in different types of alternative and complementary therapies, both nurses and different techniques and physicians. Nobody else wanted to do acupuncture, but I did. And so I was able to go get trained through a 6-month-long program and got my DC license right at the end of 2015. And the hospital was able to credential me in early 2016 to start seeing patients. So right now I have a acupuncture clinic that I do once a week here at Children's for patients with chronic pain, although a lot of my patients have very significant comorbidities associated with their chronic pain, and sometimes just sort of in association, but not really having any cause or effect related to their chronic pain. So I treat a lot of different things, but mostly pain is where we focus. And we also here at Children's have an integrative therapies clinic for our patients with sickle cell, which is very exciting. We started that, I believe, in 2018. And we hold that now twice a month. We're getting back up and running after COVID here. We are also sort of on the cusp of starting a functional GI integrative sort of therapies clinic where I will be also offering acupuncture. We'll have a pain medicine physician as well as our GI colleagues and the psychologists so that we can help some of these patients with some of whom have very significant pain among other symptoms as well. So what's been amazing is how much Children's Hospital has actually embraced acupuncture and is finding new ways for me to use it. In addition to me, I actually have another full-time pediatric anesthesiologist here who is credentialed and licensed in acupuncture. We have another anesthesiologist who works for us a couple days a week in the operating room who has an adult clinic in Silver Spring for acupuncture. We also have a licensed acupuncturist who is employed, I believe, 3 days a week with our palliative care team. So there's actually 4 of us here that do acupuncture, which is pretty exciting for an academic pediatric hospital. So what I was planning to go over today is basically looking at, I say, possible theories into how acupuncture works, because I am not sure that I'm convinced on any one exact theory that kind of holds sway for as how this actually provides pain control for patients, but we'll talk about some of the different things that we think are at play. We'll look at different scenarios in which acupuncture can be helpful, and my sort of hint, sneak peek is anything, literally anything acupuncture can help. And then at the end, I'll go over 3 different points, technically 4, but 3 different acupressure points that you guys can easily learn and that I like very often teach my patients to use at home so that they can sort of help treat themselves a little bit. I will say this is the first time I've done a acupuncture lecture via Zoom. Typically when I do it in an auditorium or a classroom or something, I bring needles and I stick them in people just because I think it's fun and people enjoy getting to see what it really feels like. But obviously I can't do that here. And if I put it in myself, it's not quite as exciting. So I get to treat someone who's never had it before. So I just wanted to quickly hit on, just for a second here, some of the difficulties in research and why acupuncture, to be honest, is actually probably one of the more, not even the more, it is the most evidence-based supported types of alternative therapies that is in wide play right now in the US. What's challenging though is to take research studies, and some of them are very small, and actually apply them to bigger groups of patients. Part of this is because generalizability with acupuncture is tricky. When I see a new patient, I get a lot of history about what is going on in terms of their Western symptoms. What is their pain problem? Do they have some kind of juvenile rheumatoid arthritis? Do they have a pediatric fibromyalgia variant? Do they have migraine headaches? And then so I take that, and then I also look at what is their sort of underlying psyche. There's a sort of a psycho-emotional component that all of us have, and you have to bring that into play in terms of how you're going to choose your points and what you're going to focus on. So in order to really standardize acupuncture treatments and to try to show that things work, you're going to have to likely standardize things that may not be exactly relevant for patients. So you may not be hitting the mark for a specific patient every time if you are trying to really generalize a treatment. So it is very tricky to actually get studies off and going. We have done one here, but it ended up being, it was kind of fun. We looked at our patients with sickle cell that had been admitted for vaso-occlusive crisis, and we could not really blind patients, obviously. We decided not to do sham treatment, but we basically just offered patients the option of having acupuncture when they were admitted versus not having it. We actually ran into the excellent problem of having way too many patients wanting to be active participants in our study. So it was actually difficult to enroll controls, so patients that didn't want to have acupuncture. And then we found most patients, after having had acupuncture as part of their treatment or as part of a past hospitalization, as soon as they come in, they ask for it again. So our study, which has been sort of partly published, we weren't really able to draw any strong conclusions about, say, reduction in opioid use, which is one variable we're still kind of sorting through our data that we collected, but we did see a pretty consistent and strong reduction in pain scores in patients who did receive acupuncture versus those who did not. So it's kind of exciting, but it's very, very challenging to design these. One other thing about sham acupuncture treatments is that often sham acupuncture treatment, so I just put a needle somewhere in your body, doesn't really matter where, it doesn't have to be an acupuncture point, may actually result in a small improvement in your symptoms. So sham acupuncture in itself can be effective. And so in order to design really, really robust studies for which you could draw really good conclusions, you have to enroll a ton of patients, which can just be, anyone who does any kind of research here knows, really, really arduous and challenging in everyday clinical practice. So the other quick point just to make here, and every time I say point, I kind of laugh, but it's really no pun intended, is acupuncture is not really considered risky. I have patients sign a consent form because that is actually DC law that I have to do that. And every time they come in, and some patients come weekly for years, I have a couple patients that do that. But our IRB at Children seems to think it's kind of risky, and I will tell you, I've never had any kind of actual problem. I've had patients get superficial scratches from some of the very, very superficial techniques that I do, but I've never had any significant problem with acupuncture. Medical acupuncture, I'll just mention really quickly, is acupuncture as I perform it. So I am a medical doctor. I do anesthesia, I do acute pain medicine, I manage PCAs, I manage perioperative problems of all kinds. And that's first and foremost what I'm trained as. I have also done a medical acupuncture course, which was a 300-hour CME credit program. And DC, as most states operate in this way, requires that physicians, in order to have a separate acupuncture license, need to complete a 250 or 300 credit hour course in order to show that they are trained in this specialty. Licensed acupuncturists are actual non-physicians who, and there may be some physicians who have done this specific training and have this degree considered a licensed acupuncturist, LAC. But that is generally a master's level. Some programs consider it a doctorate. It's usually 1 to 2 years of graduate school work at a different school of Oriental medicine or something like that. So these are practitioners who purely practice acupuncture, and I would argue they've done more extensive training and have a greater understanding of this than I do, for sure, because that is their medical training. Acupuncture for me is an additional part of what I do as a medical doctor. Now, nitty gritty, this is what everybody wants to know. How does acupuncture work? And I'll tell you, most of my patients are actually pretty reassured when they come to see me. They've never seen me before. They've been referred for acupuncture by Dr. Gray or by one of my other chronic pain colleagues who've seen it work in other patients. They come in and they're scared about needles. They want to know, how does it work? And they're very reassured that I, as an anesthesiologist, can't really pinpoint it. And I can't really explain exactly how it works, but I sort of suspend my disbelief in thinking about it in these sort of non-Western ways, and I find that it helps. So acupuncture is thought to manipulate your energy, or qi, which is, it's pronounced qi, but we spell it Qi. And this is energy that travels through these roadmaps, or I kind of refer to them as highway systems throughout the body. And there's a bunch of different ones. Principal meridians are the ones we generally operate out of, and the ones that we can kind of manipulate. Manipulate sounds a little weird, but I think it's an easy way to understand. What I'm doing is I put needles into specific points along these energy pathways. By putting a needle there, I can change how that energy works. As an aside, for kids, we actually find that energy is much more superficial. And this, again, makes me kind of feel weird as an anesthesiologist who talks about anesthesia all the time. But more kids' energy is more superficial because they are newer. They're newer beings. They have not been alive as long. So their energy is not settled into sort of more adult and more established patterns. And because of that, it is superficial and it is easier to change. So these pathways or meridians through which the qi travels is the constant thing. Your energy goes through your body. It may vary based on time of day and just sort of whatever else is going on for you. But stimulation of these will affect that flow of qi and theoretically affect disease processes. If you've heard of yin and yang, that is a balance between sort of the front and the back of the body, the inside and the outside. And it's just a way of sort of seeking balance. And so I talk about this a little bit with my patients, but mostly they just want to know, is this going to hurt? And I say, no, it doesn't. And then they're very pleasantly surprised. But this is another sort of way of approaching patients, is trying to get a restoration of balance of yin and yang. A lot of patients with pain, depending on if it's a new problem, they have acute pain from some injury they sustained last month. They may be in a very sort of yang state where they're hyperactive, their sort of autonomic nervous system is revved up. They're very sort of extra, I guess, as a way to put it. Patients who've had chronic pain for a while, you may start to see them sort of not withdraw, but maybe withdraw a little bit into more of a yin state where they are quiet. Things are sort of relaxed. It's more of a chronic condition, and so we may need to do a little bit to replenish their yin energy because that is being depleted by whatever ongoing problem is happening. So from a Western perspective, I always like to kind of think about, how does this work? Because if qi going through the body, sure, I buy that. I see that it helps patients when I do acupuncture, but there's been a lot of sort of research and hypothesis into how does acupuncture work that fulfills our Western mind frame here. So we think, what I suspect, and I think what's going on here, is that as you put a needle into anywhere in the body, really, you kind of get some pain-killing endorphins that start flowing. And these, by putting a needle in, you are sort of disrupting the cellular milieu right there. And so by putting a needle in, you are sending healing chemicals, sort of anti-inflammatory cytokines, and things start to sort of rewire a little bit. And it's an odd way of thinking about this tiny, tiny needle that we put in, but it's, I suspect a little bit of what's happening. I think there is definite engagement of the endogenous opioid system as well. I can see this with most of my patients. When I do certain treatments, there's specific points. There's one right here, kind of right between the eyes, one in the back of the head, that are very sedating and very calming. I don't use the word sedating in clinic because then they start to think I'm doing anesthesia or something. But there are definite points that really elicit a nice response where patients, you can see them kind of chill out a little bit. Sometimes they become a little chatty. Parents are always just amazed when they see this change in their child. But it's a really cool thing to see, and I see it happen a lot. I will also say a lot of this, I just can't explain exactly how it works. The other question I get asked a lot is, what if I don't believe in acupuncture? And honestly, I don't care if you believe in acupuncture. You don't have to believe in it to have it work. Turns out veterinarian acupuncture is a thriving business. I have an old friend from high school who always wanted to be a vet the way I always wanted to be a doctor. And then it turns out we both went into acupuncture in our respective fields, and she does veterinarian acupuncture. It is a thing it's very widely practiced. So you don't have to believe in it for me to put a needle in for you to feel better. So what is when I mentioned sort of the evidence base for acupuncture efficacy, it can be really challenging to establish this, but we do have the most evidence for pain problems being the most receptive to changing from acupuncture. And that is probably because a lot of the way they work is by activation of the endogenous endorphin system. So headache, we certainly see a lot of efficacy for that, and low back pain are the two that I think, at least within the adult literature, have a ton of evidence for, and these tend to be the problems that insurance will cover most readily. I have about half of my patients probably have insurance that covers acupuncture explicitly. So I treat them as often as they want to come in. About half of my patients have insurance that doesn't cover it no matter what their diagnosis is. And I see them less often, maybe every 4 to 6 weeks, as sort of a pain medicine visit. And we talk about their medications, we talk about them seeing Dr. Gray or whatever other things are going on. And then I kind of do acupuncture for them as well, though I don't bill for it. It's just something I do because that is what they need. So we also find, aside from pain, you can use it for any kind of symptom relief, for any kind of disease processes, weight loss. Everybody wants to ask me about weight loss. I use it a lot for post-op nausea and vomiting, especially in the operating room. Our anesthetics or opioids can be very noxious. So acupuncture can be very helpful for that. There's a lot of emerging evidence on using it for hypertension and for just different GI distress problems as well. Psycho-emotional distress is often very, very easily mitigated by using acupuncture. Anxiety a little bit, especially acute situational anxiety. I personally used it on myself recently. I had to travel, was having a medical test done, and I did not know how I was going to sleep the night before in a hotel. And I thought, oh, I got something. And I pulled some needles out, treated myself, and I slept solidly for 6 hours, which was way more than I was going to do otherwise. And the next day, having this thing done, the doctor there was amazed at how I looked, how I felt, and how things went. So psycho-emotional distress is a great thing to target for sure with needles. When I do acupuncture, I vary however many needles I use and where I put them, depending on obviously the patient's presentation. I usually leave them in for 15 to 20 minutes. For kids, I use it in way less, or leave them in way less, just because again, their energy is more superficial. You don't need to do as much. This picture here is the son actually of Reese, our acupuncturist who works with our palliative care group. He loves acupuncture. So kids actually do really, really well with this. What I wanted to touch on a little bit is the idea of auriculotherapy, because this is an interesting type of acupuncture that I use a lot here. And I think it has pretty intriguing applications for pain, and in some circles, and I don't do this myself, but there are certain areas that use this a lot in addiction medicine and in recovery centers. So auriculotherapy basically means putting acupuncture needles in the ear. I actually have a little sticker in my ear. I have this one point that's one of those needles you can see kind of at the top here on this patient or in this picture. And I've grown to really, really like it. So I put it in, I leave it in a couple weeks, I take it off and I put it on the other side, and I feel like it's a very centering. It's a nice point to use. It is part of basically every protocol that we use, but these work really, really nicely for certain patients. There's this homunculus, if you can, again, suspend your disbelief and think of this occurring in the ear. But I can't argue with what I'm seeing when I use this and approach patients' pain problems by looking at their ear and where I can do things. Now, battlefield acupuncture is a really intriguing sort of protocol for treating acute pain. This was originated almost 20 years ago by a physician, and what's really cool about BFA is that the military in the last decade has really embraced the use of this and trains physicians and non-physicians, so PAs and NPs, in using this particular type of acupuncture. Basically, what you do when you go into the ear, you're not putting needles in very big, very deep, because you can't. You'll go right through it. So I use sometimes seeds and beads, so things that don't actually stick in, so it's not technically acupuncture. Or sometimes I have some little stickers that the one that I have on my ear, and I have a picture of it in a couple of slides. And non-acupuncturists could do this because you're not actually doing acupuncture, you're not sticking needles in. But this is a really, really powerful tool for acute pain. And I've had a couple patients where I have done this. You just go in a very specific sequence here. You can see on the screen which ones you do. These points don't mean anything to you probably unless you know a little bit about acupuncture. But I've had really, really powerful responses with this for patients with vaso-occlusive crisis that are just in intractable pain. So this is an easy thing to use. Like I said, the military has trained a ton of people in this. I have rotating residents in our anesthesia group. They get really excited when I talk about acupuncture because they've been taught this, or they've taught the BFA protocol. It's a kind of an exciting thing, and I think has a lot of potential applications outside of anesthesia, outside of acute pain, if other people could learn how to use it. The other thing that I think is really interesting with regards to auriculotherapy, or things you can do in the ear, is the NADA protocol. And this was sort of formulated in the 70s, basically when treatment of substance abuse became a thing, really, as opioid use and other addiction problems became much more problematic in the 70s, and treatments were being sort of formulated. The NADA protocol sort of started being used more and more. And what's interesting about, well, not interesting, I think what's important to know about this is that you have to use it as part of a wider approach to substance. You can't just say, you know what, I'm an alcoholic, I don't have anything else I'm going to do, but can you just put these needles, I heard there's these needles you can put in my ear, and you'll cure me. And that is 100% not accurate. But this is just another tool that can be used as part of substance. It reduces cravings. It really kind of helps with the autonomic nervous system, and helps, I mean, I tell patients kind of things, all of these things kind of help you chill out a little bit. But the NADA protocol is, again, this is a series of 6 points in the ear. I don't typically do this with my patients because that's just not sort of the patient population that I see, but I use these points in different circumstances frequently. Things I use for the ear, like I mentioned, I have these little stick-on needles. There's this one brand called Pionex. I think they may be the only brand, so I have to buy them, and they're fairly pricey, but they work beautifully. The ones I use are literally 0.5 millimeter deep, 0.6 millimeters, and they're on a little bandage, and I can stick them on hand points, wrist points, anywhere on the body. If I have patients who are really needle phobic, these are great. But these are great to use in the ear, and I've taught people how to use these that are not acupuncturists, and they're able to do that. Other Chinese therapies I think just worth mentioning is moxibustion, which is awesome. I'm not allowed to do it here. It smells really, really bad. People say it smells like pot a little bit. I don't know. It smells bad. And so we can't really do it. But in my training, it was wonderful. And a lot of private practice places will do this. And this kind of helps treatments sort of sink deeper into the body. I guess that's one way to say it. I do a fair amount of Gua Sha, which is the idea of disrupting tension. I do it a lot in the shoulders here. you're basically unblocking chi, or I am breaking up tension or fibrosis in the myofascial layers. It looks like this when you do a good job. And often I will do this for a patient, and as I do it, I teach the family how to do it. So when they go home, they have something they can do. I do a fair amount of cupping here at Children's. What I do not get to do is use fire. I think that would be fun. It feels wonderful when you have it done, but Children's does not let me do that. And kids can be a little bit wiggly, and I don't want to use glass cups anyways. So I use a fair amount of suction cups, mostly on the back, sometimes for thighs and for arms, just depends on where their pain is. But this is wonderful. I have multiple patients that love this. Now going back quickly to when to use acupuncture, because I kind of talked about this in terms of pain, it is basically, it's most effective in acute settings. So I see patients with chronic pain problems, and I have to sort of temper expectations as far as acupuncture. It may take some time to work. I do have patients that have had unbelievable reactions after one treatment, and that's awesome. That happens sometimes. But what I see the best benefit is if someone comes in that I've been seeing frequently, and they say, you know, I wrenched my shoulder carrying my book bag and it was too heavy, and I'm able to address that one quick little problem in regards to everything else, and it is almost miraculous how quickly it can work. So acute problems, it's awesome. It works the quickest for, because that energy, if we think of it in Chinese medicine terms, has really not had a sense to, or had a chance to settle into a chronic problem yet. Evolving problems, we can also hit. Chronic issues, it just may require a longer period of time to really tackle, but I can usually get something out of it. Too often with acupuncture, as with most modalities, it's used as a last resort, and honestly, I think we need to start using it first. Couple of points to go over quickly, because I think we're just about out of time here, is this is a really, really, really strong point. It's sort of in the anatomical snuff box, we would say. So there's a little artery in there. I've never hit it, never even tried to, but I haven't. But basically what you're gonna do, it's called large intestine 4. It's a big point, and it's a point where if you kind of squeeze on it, on yourself, it's uncomfortable. And it's uncomfortable because it's an acupuncture point. Most acupuncture points tend to be tender. So this is one that is particularly important for headaches and low back pain, but honestly, I put this on everybody because it helps pain, whatever the point. This is probably the most important point I teach patients. Another one is, and this may be hard to see here, I guess I could have done a better picture, but stomach 36, and this is right below your kneecap. Basically, if you put your hand below your kneecap, you kind of roll over, it's right between your tibia and fibula. You can kind of feel it in that muscle. This is another important point, a little harder to access because it's deeper than the one in your hand, but also very important. Patients love it. I will sometimes put the little stickers on this point as well to kind of reinforce an acupuncture treatment. The other two that I think are, well, technically there's 3 here, that I find very, very important for pain in the trapezius muscles. I feel like so many of us basically carry the weight of the world on our shoulders, and so we're very, very tense here. You will have 2 points that most people can feel in your muscles right on the back, gallbladder 21 and triple heater 15. Those, if you push on them, are tender, but you can really work out a lot of tension there. And often that will help with headaches, especially headaches that encompass the back of the head. The other important one is gallbladder 21, which is you can feel up at the sort of prominence up at the top back of your head, that bony prominence there, which is kind of the way the occipital nerve travels. But gallbladder 20 there is also an important acupuncture point, but also for headache and for neck tension. So let me just scroll back quickly. Those 3 points, if you take away, nothing from this, the acupuncture is helpful, but also that this point right here in the hand is very, very, very useful. The one right below the knee, kind of rotated over a little bit, also very, very useful for pain. And these points in the back, strong sort of pressure just sustained there can help with tension, or you can do a little bit of a massage, whatever is comfortable and tolerable for you or for people that you are talking to. And that is about all I got. I think I pared it down mostly enough here. So, and I have a couple references that I threw in.
Okay, great. Thank you guys so much for your presentations. I certainly learned something new, and I'm sure others on the phone did as well. So we're going to go right into Q&A. If anyone on the call has questions, just drop them in the chat and we'll get to them. We have a couple right now. The So one of them is for you, Dr. Reese. So first of all, thank you for sharing some of the evidence of acupuncture. But I'm wondering if you can share a little bit more about that evidence, because I'm sure, as you know, it's hard to get people to understand acupuncture in the medical field. And I know as an anesthesiologist, you have to have those conversations with patients and also with colleagues.
Yeah.
So can you talk a little bit more about that?
About the evidence? Yes, you bet.
Yeah.
So I kind of purposely today decided not to just go through, here's a study that these people in Poland did, and here's one that people in Italy did, because I didn't do the studies myself, and I don't, with only 20 minutes, it didn't seem sort of the best use of time. I just wanted to provide an overview. But there is a lot of evidence. What is challenging, like I said, is to produce research studies that sort of hit everything that we are looking for in terms of a very robust study. Our study here, when we looked at acupuncture in patients who had sickle cell, we saw a reduction in pain scores by about 1. That does not, over the course of a hospitalization. Now, a reduction in scores of 1, in my mind, initially, until I started looking into it, did not sound convincing to me. Is that even worth it? But as reduction in pain score of 1 is a very, very significant in terms of functionality, and it has been validated in many studies to be important. So if you do, as part of the training that I did, we have access to sort of a repository of studies, and I think I have about 1,000 on there looking at acupuncture and its effectiveness in a variety of clinical scenarios. What's tricky about acupuncture, and I think about everything, is that you're not going to see studies published that don't show an effect. So you're only going to see the things where people say, yeah, this was great. So I always tell families that I am regularly stymied, sometimes by patients' presentations. I have patients who do spectacularly well with acupuncture that I had not anticipated being able to help. And I have patients where I'm pretty cocky and thinking that, oh, for sure I can help you here, and then really not being able to do much for it. So again, the evidence is very clearly out there. I think in the US right now, we are getting better at covering it from an insurance perspective. Every year, I think I have more and more patients who have good acupuncture coverage. And I can see that in the last 4 years that I have been doing acupuncture here. And I think that is a reflection of emerging studies that are showing that, yes, this is helpful and better than medication and well tolerated in a lot of circumstances.
Thank you. One more for you, Dr. Reese. For the ear points, how
Yes.
long should the pressure be applied apart from wearing the pads for weeks?
Yes, so that's hard. So ears, if I'm putting actual needles in clinic, which I do sometimes, and sometimes for my inpatients with sickle cell where I really, really want to get a good effect, usually I leave needles in for 30 to 45 minutes. Now, part of the reason we suspect that, which is longer than I would tell someone to use just acupressure, like to the hand, where I would say, massage it for 2 or 3 minutes. There's another point for nausea, kind of where people use C-bands, if you ever see that. And that kind of massage for those points just for a couple minutes is helpful. Now, the problem with ears is because it is acting through a central input, theoretically, it takes longer and you need a little bit more there. So I don't know that just massaging points in the ears is going to be helpful. What I have sent patients home with, because I won't send them home with these little stick-on needles, just because, again, it's not really acupuncture, but I shouldn't send patients home with those. And I'm restricted to buying them as an acupuncturist. I will send them home with seeds and beads, and you can buy those on Amazon. So I usually tell patients in the ear to leave things on for at least a couple of hours. And the reason, again, for that is because it's theorized to be working in a little bit of a different way than other acupuncture. It's a central input, and you're really trying to change the way the brain is perceiving signals, and it just takes a little bit longer. Scalp acupuncture, which I didn't go into either, also takes a couple of hours usually that you want to stimulate it.
Great. So I wanted to ask Dr. Gray one question before we wrap up. Can you talk about the current payment models for behavioral pain medicine?
Yeah, I'm sorry, the current what models?
Payment models for behavioral pain medicine.
Certainly. So currently, mental health care is a required coverage under any insurance plan. So we Typically, we are looking into authorizations before we are seeing patients, but patients, as long as I am paneled on their insurance, then the treatment is covered. There's the same as any sort of psychotherapy service. I will say that hasn't always been the case, that it used to be more like acupuncture, that it was variable depending on the insurance plans. It is not uncommon, though, that insurance companies farm out the coverage to a different provider. So it might not be that it's the same provider that they're paying to one insurance company, but it's a different provider who provides the mental health coverage.
Great. Thank you. So it looks like we're at time. So I just wanted to thank our speakers once again for joining us this afternoon. If you stay on till 1 p.m., our next session is integrating peer support workers to enhance SUP services. So we hope to see you then. Thank you.